translational research, improvement science. Some, including Sarah Green, who's one of the original minds behind the term and concept of a learning health system, have even pointed to the fact that we might need to use different terms and phrases to really resonate with the different audiences that we need to talk to about this work. And as implementation scientists, I think we can all relate to the challenges of jargon that plagues our field. And so call it what you want. But I do think that this new term of learning health system has also provided more focused attention and interest and more structure to us following this North Star, which I'll describe in a little bit. And whatever you decide to call it, it is really about achieving synergy between research and practice, in which research informs practice and practice informs research. Ultimately, this translates to relevance and generalizability, doing things that are relevant to the local context in a way that is externally valid and reproducible by others. I also think the parallel of the relationship between a bee and a flower and how they benefit from each other in a mutualism relationship is really similar to what we're trying to achieve with learning health systems, in which we find this relationship, the synergy between clinical practice and research. And when we think about a learning health system, the day-to-day work really occurs in the learning cycles, which are conveyed very nicely, I think, in this figure. And this figure is probably the most common depiction of a learning cycle, and it comes from Sarah Green, who I mentioned earlier. And in this figure, it emphasizes the need to look both internally. Can you see my mouse, or am I just waving around for no reason? You can? Okay. Perfect. So it emphasizes the need to look internally as well as externally to the health system or organization to understand a problem, identify means to solve that problem, and then you design it in a way that makes sense internally for your health system. Of course, you implement, evaluate, and you do it all over again. So it's very much so an iterative process. And here's a modification of the original figure that I really like. And I like it because I think it simplifies and to a degree demystifies what learning cycles are by drawing a similarity to the PDSA or plan, do, study, act cycles that are commonly used in quality improvement. But this figure still emphasizes the importance of looking external to the health system and disseminating the findings externally to your health system. So just to kind of bring this together, I'm going to provide a really quick and simple example of one learning cycle that we did at UC Health. And I think you'll see in this example that a learning cycle really is, in theory, simple. It's anything we do to study or promote change. So in this particular example, we were focused on finding ways to improve guideline concordant prescribing for heart failure. And this particular issue represents a really big care gap for a high-risk population of patients, not just in our health system, but it's a care gap that really persists nationally and internationally. And so in order to tackle this problem, we wanted to understand the issue. So we looked in the literature to see what has been done to address this. And we also looked within our own institution to see what we currently were doing and have done. Ultimately, what we decided to do was implement an alert within the electronic health record to nudge or coach providers to prescribe these medications. And we designed this alert to overcome some of the limitations that we identified in the literature external to our health system. And we just also designed the alert using an implementation science framework, specifically PRISM. And we also engaged partners across different levels of the health system, including patients, frontline clinicians, and also executive level leadership to make sure that we were doing it in a way that made sense for our health system. And then what we did is we implemented the alert in a pragmatic randomized controlled trial in which we compared this new alert we designed to a traditional alert. The traditional alert is essentially what was considered the standard of care at the time. And we did this randomized controlled trial in a way that we didn't need to consent patients or clinicians because it was truly embedded and it was aligned with the quadruple aim of improving patient care, clinician experience, efficiency. So it was truly an embedded project. And then, of course, we evaluated it using mixed methods and really aiming to understand outcomes that were important across the different perspectives of the people involved, including the decision makers. And of course, we refined the alert over time, and we have many plans to continue to refine it. And we have scaled it up. So our new alert that we created, we have since expanded it to all clinics. And we also have shared it in the literature in publications that others can learn from what we've done. So this is a very simple example of what a learning cycle is. But beyond the learning cycle, there's the infrastructure of a learning health system. And the infrastructure is what supports the learning cycles. And every learning health system has a different type of infrastructure. But generally, I'd say they fall into these three different categories or general models of a learning health system. The first of which is a centralized model, which includes a formal governance structure and standard procedures for prioritizing issues to guide the learning cycles that are prioritized. And then those learning cycles that are prioritized, the governance structure or committee offers resources and support in the form of expertise to actually conduct the learning cycles. In other words, there's a committee that vets the different projects and then helps support folks to complete the learning cycles. I'll present later another slide that mentions the Vanderbilt Learning Health System. And if anyone is interested in learning more about what a centralized model might look like, they have a really great paper. That's a good example. The next sort of general category of a learning health system infrastructure is more consultancy-like. And so these types of learning health systems primarily serve consultative roles. They're often housed within academic centers, and they offer extensive methodologic and analytic expertise. However, they may be limited in that they're not a standard part of a health system's learning cycles. They might be separate. But the advantage of this is they're able to really reach beyond their resource wealthy setting and help other people that might be in lower resource settings who want to work on learning cycles. And then the final or the third model example that I have here is decentralized learning health systems. And these are often data networks, and that means they essentially pool data from different data sources and settings. And then they make that data readily available for other people, other institutions who want to use that data. However, oftentimes they don't have the methodologic or analytic expertise, or they don't provide it to others, which is needed to be able to analyze and use that data. So settings that want the data need to make sure that they have a plan in place to actually use the data for the expertise. Another important consideration with these decentralized models is that if the data doesn't come from your specific setting, you need to really consider the relevance of it. Just because the data doesn't come from your setting doesn't mean the data isn't relevant, but there are some situations when it may not be. All said and done, this is a hard thing. And achieving this, what I'm calling mutualism relationship, is hard for so many reasons, including the fundamental issue of health systems are complex and dynamic systems that change rapidly over time. And the saying of if it was easy, everyone would do it certainly applies in this case. Those that don't do it those that do decide to do it really demonstrate a commitment to excellence. And fair warning, I love the early talk about mugs and inspirational sayings because this is one of the first of a few that you will see throughout this talk today. I think motivation is important when we're talking about learning health systems, so there's lots of it. Where do we need to go? This is where the North Star comes in. Our North Star is a fully mature learning health system. And it really boils down to us being persistent. That was mentioned before I got started as well. A fully mature learning health system is truly aspirational. It's a goal, it's a moving target. And we will honestly never, no one will truly ever achieve the status of a fully mature learning health system. There are constantly rapidly emerging innovations in technology, data, evidence-based medicine that require our methods and our targets to adapt in order to get to this place. And sure, as soon as I tell you all of this, it sounds really deflating and defeating and daunting, and you might tune out. But it's the reality, and it's important because it's us demonstrating that we are doing the best that we can for the people who put their trust, their lives in our trust. So it's a demonstration of commitment to excellence and a quadruple aim: improving quality, equity, value, efficiency, and experience. And while there are many challenges, many of them are well known, and we'll talk about a few of them here. The challenges really vary based on the setting. Every setting has unique challenges, and we'll kind of talk a little bit about that. One of the key challenges is system and policy level support in the form of financial support, as well as training programs. And these are both important from a sustainability and capacity building perspective. Financial support, when we think about healthcare, learning health systems are part of a healthcare. And so healthcare reimbursement really happens by two main means these days. We have value-based reimbursement, and we also have fee-based. So we get reimbursed based on time spent with patients. But you know what we don't have? We don't have a reimbursement method for learning. And I don't mean reimburse for tuition. I mean, if we are supposed to continuously improve and innovate so that we can do the best for our patients, not all those times are going to be successful. So how do we make sure that it's viable and there's incentives in place for us to continue to be motivated to learn? And then the capacity building, we need to make sure that there's a workforce capable of carrying out the mission of a learning health system. And so we do need support for training of our future workforce. This is where methodologic and analytic expertise. So depending on your setting, most learning health systems are academic settings, which are resource rich, full of expertise. But if you don't have that expertise, say in lower resource settings like federally qualified health centers, it makes it really challenging. So this is often a big challenge to doing learning health systems in the real world outside of academic centers. And irrespective of whether you're resource rich or resource poor, data is always a challenge. Even the most resource-rich settings struggle with getting data that is accessible, comprehensive, meaningful, useful, and inclusive. So there's definitely challenges there. Engagement of partners is time-consuming for everyone, and some people struggle with identifying the best ways or even how to do it. We know it's a spectrum, and at the best end of the spectrum, where we get to that true co-creation piece of things, it's intensive. And ideally, it should be beyond just talking to the folks within our organization. It should extend to patients and community members, which is, again, resource intensive. Finally, this challenge listed here is not the last challenge, but it's one of the common ones, and I think it's probably the most challenging. And this is because it requires a culture shift. So achieving that synergy between research and clinical enterprises is hard. And so I think that's one of the most notable challenges. Changing culture is hard. Despite all, yeah.
Before you go on, if you don't mind, just going back to that last slide for a moment there, thinking about the system and policy level support that's needed. Is there such a thing as an official designation as a learning health system, like the patient-centered medical home? I'm thinking that has sometimes been really helpful in driving change, when there's an actual kind of policy in place and then people are evaluated based on meeting the criteria to get that designation. Does that exist?
First, I'm going to say I love that thought. It exists in certain degrees, but not in the manner that you presented. And I fully agree. I think that the designation and clear criteria of how to become designated learning health system would really help push this. So right now, really anyone can call themselves a learning health system, and I'll tell you later that that isn't inappropriate. But through AHRQ, that's probably maybe the best place if you have funding or some sort of recognition from them. Maybe that's what the current gold standard is, but it's not achieving what you set out, what you proposed. Really good comment. Anything else before I move on?
Nothing in the chat, Katie. Thanks so much.
Okay. So despite all the challenges, it is possible. So I kind of I'm taking you on this roller coaster ride. It's great, it's important, it's exciting. Oh, but hey, there's all these curveballs. It's possible. Look, here are some exemplars of learning health systems. And I kind of tried to pair them with these different models that I shared with you earlier. So Vanderbilt, I already mentioned, University of Michigan, George Washington, PedsNet, and DartNet. But also, did you know that you have a learning health system? There's one baked within your family medicine department at UCSD. And I'm sure there's many other initiatives, whether they label it as such or not, that are learning health systems at UCSD. And so I think it's important to point out that there's pros and cons of every learning health system. And there are absolutely, not now, not ever, any perfect examples of a learning health system. But the important thing is you do what you can with what you have. And although we often say things like, oh, well, they're not a true learning health system because of X, Y, or Z, it's important to note that it's not all or nothing. You do what you can with what you have. And depending on what you're able to do, learning health systems really fall across the spectrum of maturity. So Nicole, what you're describing, maybe that's the primo spectrum of learning health systems, and you get that designation, but you have to demonstrate that you've met all of these criteria. And so there are examples across the spectrum, and I really like this paper because Lannon et al. Really lays it out, and they say it is a spectrum, and you can use this particular maturity grid that they've developed to, one, evaluate where you fit on that continuum, and two, also use it as sort of a framework of how to improve and get to that next level. So maybe we already have the workings of getting to where you suggested, Nicole. The other thing I hear people say a lot is, okay, so tell me how to do it. This is really great. But there is not one way. It's not one size fits all. I recently heard Brian Mittman give a talk on learning health system, and he likened the how to do a learning health system to the form and function concept that we often use in implementation science, and I loved it. So I'm going to share that with you. So bottom line is, it doesn't matter how you get there if you ultimately get to the same place. A learning health system takes on many forms to achieve the same function. And ultimately, learning health systems aim to maximize relevance and generalizability. This is something that is hard to find the right balance between, but it's also something that dissemination and implementation science is really good at and offers a lot of tools and methods and principles to get here. So with this general framing in mind, I want to spend some time now transitioning and talking about, okay, how do we get closer to this North Star? And how does dissemination and implementation science help us? Before I do, though, I wanted to take a pause and see if there's any questions or thoughts.
Katy, I love the terminology of, North Star, and I'm sure it's very intentional. And I'm thinking about the work that Nicole and I have been undertaking with our community partners to create a theory of change, where you set a very inspirational North Star, which you might never achieve, or you will not even get close to within one study, but you kind of work back from that to the how. And so I very much look forward to what you are proposing as how do you get closer, because it seems to kind of metaphorically be very similar to when you do something with a community and you know that you will never achieve that optimal situation, but you get closer, and that's success.
Yes, I love that. Well, I look forward to reading that paper when it comes out.
This is wonderful. One thing that has come up a lot in my studies of learning healthcare systems is the funding, which you definitely touched on. And I know that Geisinger has been kind of held up as an exception because of their own funding structure. But you also pointed to how UCSD, for example, has the learning healthcare system, and they also have in their own insurance structure. Is that an opportunity for us to kind of maybe take a smaller chunk of the pie without having these same kind of funding concerns between, is this a research activity or is this a clinical billable service?
Yes, absolutely. I love, there's lots of layers to what you just suggested. And I'm latching onto a lot of them. And I think you'll see some of them come up again. But yes, so there's this saying, I don't know, when you think about anxiety, you think about our workloads. How do you get started? Sometimes it's just so overwhelming. So how do you eat an elephant? It's huge. It's enormous. You take one bite at a time. And so I think when we talk about learning health systems, it's exactly the same thing. It doesn't have to be all or nothing. It might be one learning cycle and then the next learning cycle. And then you have what Sarah Green, I've heard say, transition from the RO1 to the ROI, which I think is really fascinating. So the RO1 is the intensive research dollars, but it's short-lived. And if you have enough of those ROIs or quality improvement projects that collectively demonstrate value, then you have your return on investment. So yeah, I love what you're saying. Funding is hard. Is it Susan?
Hi, I was just thinking, I don't know if you guys have seen this from as a family physician perspective. One thing they have that we're actually required to do every 3 years is a performance improvement project for your CME to get recertified. So all family docs have to do this, and most family doctors will get money for CME. So if there is some way you could involve the organization stuff around an activity that included primary care physicians who were family medicine board certified, and they could get money through their CM, maybe if at an organizational level, that you had a family practice department or something like that, where everybody needs to do one of these things. I organized one for COVID for my practice I was working in. And so everybody was so thankful. I did all the hard work and got it all set up, and everybody just had to answer a few questions. And I didn't get outside funding for it because I offered to volunteer to do that. But I could have, you could say, well, why don't you get CME dollars for this? And if they're willing to put money into CME, and that provides CME, which also creates this learning culture, that might be a way to access both buy-in from doctors that are they're getting something done that they have to do anyway. And then an organization might be willing to put some money behind it.
I love that. I think that's an excellent point. That's not something that I had thought of, and I very much appreciate you bringing that up. I think it's an excellent idea. Can help build the sustainability of this.
Yeah, like one of the things I'm trying to work on right now is the ACEs that I'm sure most of you are familiar with is a big hot topic right now. And there's actually online, the California Academy of Family Physicians has a way to get to do this. And then the doctors have to do some data, but to do that as a larger picture, you could do something like that. And people would, I think you might be able to find some money behind that.
I love it. And I love that it's not the traditional approach of thinking about getting money, which is asking, your institution or getting grant dollars. It's really feeding into other lines of infrastructure and incentives. Wonderful. I'm taking notes, by the way. I love these ideas. All right, I'm going to move on, but don't hesitate to interrupt. The discussion's great. So this looks intimidating, just like a learning health system. Don't worry, I'm going to break it down. But in order to illustrate, so now I'm going to transition into trying to really identify and portray where dissemination and implementation science fits into a learning health system, while also capturing the complexity of all of this and providing some direction on how to address these many challenges that we face. We created this framework so that other health systems can use it to try to improve and work towards the aspirational goals of a fully mature learning health system. And so to give you a better understanding of what's involved in this ideal visionary concept of a learning health system, I'll walk you through this. And I want to point out before I break it down that with few exceptions, this framework is not novel. It simply integrates the work from others into one place. And I will articulate where we did steal, like artists. There's a book. I'm going to share that with you as well. And I also want to highlight that it doesn't look like the traditional Venn diagram, but this is intended to be a Venn diagram. It's just a horizontal Venn diagram. And on the left here is the core of this figure and the core of a learning health system, which is at the health institution unit level within the organization. So lasering in on that left portion of the diagram is where really all the work is done within a learning health system, the learning cycle. And these learning cycles focus on rapidly and iteratively identifying and problem-solving issues. And when we do learning cycles, it's important to avoid trying to get it perfect, but focus on getting it good enough while ensuring that there's no harm. It's healthcare. So we need to ensure we practice the fundamental principle of do no harm as we try to improve. So with this mindset in mind, the goal is achieving what Borshika has heard me say so many times, the MVP or minimum viable product. In other words, trying to be agile and nimble, but this is definitely hard. And it's especially hard because this isn't the way that healthcare or even academicians are traditionally wired. We get so stuck and lost in achieving perfection that great really doesn't even have a chance. But when we allow great a chance, we can move faster. So rapid is key to a learning health system, but it's hard. And something I want to point out about this learning cycle of our figure is that it really builds on the classic learning health system model created by Green. But it's different for a few ways because it emphasizes some things. Notably, when identifying the gap, the problem, it emphasizes the importance of considering and analyzing the context. And when planning or designing a cycle or intervention, it should prioritize doing it in a way that's sustainable locally, but is also externally generalizable. So you can see these implementation science principles coming through. And then when you're implementing the thing, it should be done pragmatically and allow for flexibility that's required in the real world messy situations. And then when you're evaluating, it should include pragmatic outcome measures that are relevant across the diverse partners involved, including decision makers. This learning cycle also integrates terms from the quality improvement PDSA cycle I showed earlier. As you can see, the Plan, Do, Study, Act is integrated alongside the more classic researchy terms that we traditionally use. And this is because QI is critical and it requires integration of improvement scientists, quality improvement, performance improvement folks with the research folks. And we'll talk more about this in a little bit. Taking a step back, some of the broader features of this framework, an overarching principle is systems thinking approach, which is absolutely necessary to capture the complexity and dynamic changes and interactions that happen within our very complex system of healthcare. This framework also builds on a socio-ecologic model in which mature learning health systems include active, ongoing partner engagement across all levels. And with with greater diversity and representation of engagement across the partners, we also promote equity and sustainability. There's more people give their perspectives, you account for more things in what you're doing, build sustainability, and promotes equity. And then engagement and support at each of these levels aims to provide different types of support and input for learning cycles and the overarching learning health system infrastructure. So now I'm going to break it down and talk about the contributions of each of these different buckets here. So thinking about the bucket of organizational level, key contributions and perspectives include forging a shared vision between evidence-based practice and practice-based evidence, so clinical and research. Also integrating transdisciplinary partners, including patients, with an equity lens to promote health equity from the beginning. And of course, there's a need for organizational prioritization of the resources and data needed to support the learning health system. The organization has to invest in the resources that are required. At the community level, key contributions and perspectives include creating new partnerships across health settings, but also between health settings, and others such as technology partners and community-based programs, and then aligning goals and priorities of these different folks, and creation of things like health information exchanges to share data and support data harmonization efforts, such as what is done with groups like Odyssey, to transform data into usable and actionable formats. And then engagement at the policy level is key to capacity building and sustainability. And we've already talked a little bit about this, but it's through regulatory actions and quality standards, but also through financial reimbursement mechanisms that support not only volume and value, but also support learning. And then capacity building by supporting training and education programs so that we have a means of developing a future workforce capable of carrying out the mission of a learning health system. However, I will say that engagement at this level is not very common, unfortunately. Now, separate from engaging these different partners, the overarching learning health system model or governance structure can function at any of these levels as well. So to provide some examples, so at the public policy level, there's really two examples that come to mind for me. There's the Swiss model. They are developing a learning health system at their national level. And then PedsNet, which I mentioned earlier, is more of a data type network. An example at the community level is ADAPT. And this particular learning health system aims to connect at-risk youth in the juvenile justice system with mental health services in Indiana. And knowing that this is at the state level, some could argue that it is more at the policy level, but it's still within the state of Indiana's community. So the lines are not so clear. More commonly, what we see is learning health systems that function at the organization or unit level. Familiar examples include Geisinger, which was mentioned. And Geisinger, for example, focuses on learning health systems in specific specialty areas like cardiology or precision health versus being more all-encompassing and generalized. The VA and the Kaiser are examples of learning health systems that are more generalized and not focused on a specific area. And although there are certainly fewer examples at the higher levels of the socioecologic spectrum, so the public policy level, the population impact of those that occur at those levels is anticipated to be greater, and the sustainability is much, much higher, more likely to be sustained. But when we involve those higher levels of the socioecologic spectrum, generally we might slow down. So sometimes we think that there might be a little bit of tension between the population impact and engaging or acting at a higher level compared to the rapidity that might be needed. So these arrows kind of try to highlight that tension that can occur between the rapidity and the breadth of the impact. The final aspects of this framework that I want to review are the key components, concepts or methods that should be used together during the learning cycles. And it really is in concert. And it's not just at the beginning of the learning cycle, but it's throughout implementation and evaluation stages, when you need to consider contextual adaptations and sustainability beyond the study or evaluation period. The first of these components is informatics. And this includes the tangible data, software, technology, but it also includes things like artificial intelligence, clinical prediction models, as well as expertise and standards, ontologies, and harmonization efforts that make data shareable and usable. This also includes practicing principles that promote interoperability. Along with informatics, and sometimes the lines might be blurred, is precision health, which calls for inclusive integration of holistic data sources that impact health and allow for individualized, equitable care. And I want to note that to achieve the goal of precision health, we need to consider data sources beyond what is currently available in the EHR. Earlier, I mentioned the EHR really has been opened up the bottleneck for learning health systems, but there are still limitations of the data in EHRs that do limit learning health systems and what they can do. So it's important to consider data sources beyond the EHR, things like social determinants of health, which we know are very inconsistently and infrequently documented in electronic health records, but also social and behavioral data, patient-reported outcomes, data from wearables and devices. So much of healthcare is delivered virtually now. We need to be looking at remote types of data to help our patients. And as we think about precision health, it's important to not just focus on the new shiny aspects, such as genomics, but also to prioritize the data we know makes a difference, especially social determinants of health, and not limit ourselves to just data in the EHR. And I'm not trying to say that genomics is not important. I'll be the first to say I think it is important, and I'm involved in some efforts related to genomics and getting it into clinical practice. But we need to remember to not forget the known, and we know some things like social determinants of health can be predictive. No surprise, partner engagement is also an important component, which we've already talked about a fair amount. And when we think about partner engagement, it should be representative across the socio-ecologic spectrum of those who are directly and indirectly impacted, and be iterative to account for the dynamic and rapid changes that occur in healthcare. With representation of diverse perspectives, the work becomes more relevant and also equitable. Not only is partner engagement key during the planning stage, but also in the implementation and evaluation stages to inform adaptations and make sure we're evaluating outcomes that matter to diverse folks, and making sure that we share those outcomes back to them in ways that actually reach them. And finding ways to reach them can be challenging, but it's important and doesn't necessarily include our standard peer-reviewed publications. I already mentioned quality improvement is important, and it's really central to learning health systems. It brings a culture of improvement and iterative methods that are contextually relevant for a setting or health system. However, a potential limitation of QI is that it can be limited by generalizability, which points to the need to use it with other methods and concepts. For example, when we merge QI with pragmatic approaches, QI can be elevated and be externally generalizable. Pragmatic methods and outcome measures are both practical and robust, and they prioritize issues of relevance to partners, rapidity and recursiveness of findings, replicability by others outside of our health system, rigor in real-world messy situations, as well as considers resources required for feasibility and sustainability. And so these 5 bullets I have here are really the 5 R's model of pragmatic research. Last but not least, the elephant. So this framework includes integration of dissemination and implementation science. With its focus on external validity, dissemination and implementation science increases the likelihood and speed of translating evidence to practice. So we don't have to wait 17 years for, 14% of evidence to actually make its way into practice. And implementation science also provides on how to maximize some challenges that aren't commonly thought of, including sustainability, scalability, dissemination. And we really need to take one bite at a time. And that is what we're doing at University of Colorado. So thinking about this aspirational framework, I thought I'd share with you a little bit about where we're at on our journey to achieve this. It really is one bite at a time. And you can see, so there's really three different things I'm going to present, two more coordinated efforts. The first of which is a relationship between University of Colorado and our health system, UC Health. And this is our longest standing coordinated named effort to promote a learning health system. And as this logo says, the NAV Lab uses advanced data science and evaluation methods to drive the delivery of high-value healthcare. And I would consider NAV Lab to be a centralized learning health system model in which individuals from the health system will pitch ideas to the NAV Lab, and those that are prioritized are supported by NAV Lab's very diverse research expertise. But I want to point out this is a little bit different than the NAV Lab or the learning health system going directly to the leadership of a health system and asking them what their priorities are from that high level perspective. What NAV Lab currently is individuals coming to them, then the NAV Lab vetting the projects with the health system's goals, needs in mind, but not necessarily always outwardly asking. And so this is an area where, as an informaticist and academician who plays in both sandboxes, I'm trying to blur that line a little bit better so that there's better integration between the health system and the academic side and greater sharing of resources so that the work, and also so that the work really focuses on the highest priority issues. The NAV Lab's doing a lot of really great work, but we still have a lot of work and ahead of us to really achieve our goals for sure. Something I'm excited to share is a new venture for us. So University of Colorado is partnering with our Children's Hospital, which is also on the same campus as us, to establish a learning health system. And this learning health system is focused on helping children and adolescents with mental health. And we're starting with suicide prevention as our first priority in our first learning cycle. So this is pretty exciting and it's different. It will be designed differently, is being designed differently, and executed differently. Something else I want to share that I've recently been reflecting on, and I'm excited to say, is that our learning culture is really growing at University of Colorado. And this is independent of any structured, coordinated effort, which are important. But what I'm finding is that researchers and clinicians are starting to adopt the learning health system mindset, whether they call it learning health system or not, they're adopting it. And clinicians are starting to reach out to researchers more, and clinician researchers are prioritizing work that's directly relevant and generalizable to our health systems, rather than starting with, okay, I got this research project. It's starting with, this is actually to improve patient care, and we're going to also evaluate it. So I think this is pretty exciting. All right, I mentioned Steal Like an Artist already. As framed by the book Steal Like an Artist, no idea is original, and we absolutely stole like artists to create this framework. The framework we presented is largely the product of integrating the work from others, but there are some unique features of this framework, including implementation science. Others have certainly used dissemination and implementation science in their learning health system, but this framework that we presented formally integrates its methods and approaches with other well-known methods that are essential to learning health systems. And it also prioritizes under-recognized challenges learning health systems face that are particularly important to implementation science. specifically sustainability, generalizability, and scalability of the learning cycles. This model also aims to improve guidance on how learning health systems can promote equity, notably through inclusive precision health that comprehensively and holistically integrates data that impacts care decisions, and by ensuring partners engaged are truly representative, not just representative of the norm, but inclusive of outliers and those that have been historically marginalized or disadvantaged. All right, I recognize this is a lightning speed overview of a very complex, big topic of learning health systems, and you surely have many questions, which is good. I would love to continue the discussion, but I hope what I'm leaving you with is an understanding that becoming a truly mature learning health system is aspirational, and it is worth our persistence. It gives us a mark to strive for, as Borshika said, and a mark to do better. Many have already made tremendous progress towards this aspiration. And yes, while there are many challenges remaining, these challenges also point to opportunities, notably to advocate for changes in culture and policy, the need for transdisciplinary engagement across sectors, and integration of diverse perspectives and expertise. This certainly requires us to be persistent keeps coming up. And I'll let you think about what other inspirational quote makes sense to you, because clearly this is hard stuff, and we all need to define what our own motivation is to do this. So with that, I worked really hard to make sure that there was time for discussion. It looks like there is. So I'd love to hear from you all. Yes.
Thank you so much, Katie. This was such an engaging presentation. I learned so much. I see we have at least one question from Borshika in the chat, so maybe we start there. I also have a question that I'll wait till the end and invite others to go first. But Borshika, do you want me to read yours, or do you want to share?
I can very quickly say that, Katy, you talked about this a little bit, but I think that we seem to be I don't know, humans who need to feel that we are thriving towards something, and we like to measure our little successes. So could you speak to, how do we measure success in terms of building learning health system? And then also, what are small wins versus, a big win?
Yeah, I think that's a really good point and important to consider. So one, I think that the maturity grid by Lannon et al. Is one way, you can see where you fall, and it provides, validation if you've done a really great job, but also tangible next steps for ways to improve. I also think there's small little things that are actually very high yields that we can consider. So sustainability. Have you moved from soft funding to hard funding? I think that is perhaps one of the biggest milestones and victories for learning health systems. It was mentioned Kaiser. Those are integrated healthcare systems. It's different, right? Does it apply to us in academia? Maybe not, but there are examples. Vanderbilt is one where they have been able to demonstrate the value over time and have hard funding. So I think funding is one of those metrics, but then I think you can break it down more granularly, thinking about things like the maturity grid. Others thoughts? Actually, that's a really great question just to ask the group. What do you think are some of the best tenets to demonstrate that you've succeeded and done good work in a learning health system?
I mean, I'm just thinking, do you count how many good ideas were generated, or how many times this set of interactions informed some decision? I'm just trying to think about measures that would be aligning with that.
Yeah. Susan, I was pretty inspired by your suggestion of, really leveraging the structures that already are that clinicians are already held accountable for, performance improvement, and maybe a metric of success is the diversity of folks who get to do this stuff.
Yeah, I mean, to me, this is Greg Ahrens. Hi, Katy. Thanks for the presentation. This is very broad reaching. So, yeah, I mean, I think in terms of tangibles of success, but I think, you know, a lot of the examples were specific initiatives. So if there's a good way to pull those together, because it's, you know, if the title is Learning Health System, let's think systemically, right? Rather than individual initiatives, what's the cumulative impact on the quality and outcomes of healthcare, or the types of things that I'd be thinking about? And, you know, to the degree that those can be captured within EHRs, that would be easy, or I should say, but you know, there, as you know, there are limitations to our EHRs as well for giving us the kinds of nuanced information that could really characterize a learning health system, I think. So, you know, you're talking about multiple sources as well, I think is really important in thinking about how we pull it all together.
Yeah, really good point. And, you know, some of the things you just mentioned, Greg, take me back to Nicole when she said, you know, is there some sort of designation and the criteria? Thinking about what type of data you have in the EHR, how you use the data in the EHR could be metrics of that broader system as opposed to a specific project or learning cycle. Christina, I see your hands raised.
Hi, let me lower this. Thank you for this wonderful talk. I have a question about data and using EHRs to study QI processes. I know that when I've worked on prior initiatives, embedding different things in the EHR can take a really long time, especially if you're in a complicated health system. And so it's really hard to do that, and yet you don't want to have people have to double document and all of these different things. And so wondering how you do things at your organization to kind of collect the data you need to encourage these learning cycles, but also recognize that changing EHRs can be very difficult for a lot of places.
It's an exceptional question. You know, I think I've faced that issue my whole academic career, which is also the reason, really my inspiration, I think, for pursuing a role as a clinical informaticist, that I had more control and I could do more. But that doesn't help you and the general folks. Even that said, I mean, I still have to go through a governance process. I can't just do whatever I want. But I think the key is it's finding the balance, of course. It depends is always the answer. But if you can justify what health systems want to hear when it comes to making changes to the EHR is that the data and there's a workflow and it'll be used, whatever the change is. And the primary goal and function of it is for patient care or some metric that they have to stand behind, whether it's reimbursement or whatnot. So if you can build a case that, hey, this is going to save you money, it's going to help patients, it's going to improve clinician experience, there's a good likelihood that you'll get it done. I think it also depends on your health institution and how much support they have to build these things. And if you can't get someone to build it, yeah, unfortunately, we kind of have to make do with what we have. And it's not always perfect. I don't think I really had any great insights for you.
No, thank you. That is helpful. It does seem to be a common challenge, but I was just wondering if you guys had figured it out, but it sounds like you're making inroads at least yourself. So thanks.
Yeah, but I do, you know, one of the things I do see a lot is people don't know how to frame the ask. And so when you want something built in the EHR, think about what actually matters to the people that are deciding whether to invest the resources to do it or not. Jonathan?
Thank you. Really very, very thought-provoking presentation. So a couple of points that I just wanted to explore. So at what point do we get to when we hold ourselves accountable to public health impact? We have the ability, I know that these are long-term propositions, but presumably we're all in this for the long haul, and we're building data systems. So that leads me to the other question, aspirational question, the kind of interoperability across data systems that would allow networks of networks to function together, PCORnet being just one example of those, but there are many others. And then really at the kind of far end of this, I run a practice-based research network that works with federally qualified health center clinicians, and they have great insight, great interest, but the recognition and reward system for a practicing clinician is very, very different than what it is for an academic investigator. And so I think one of the challenges of bridging that translational gap is to understand that they're not the same reward systems. And while at one level, everybody may have the same goal of improving population health, improving clinical outcomes, the way that we get there is very different, whether you function within an academic system as an investigator or as a practicing clinician in a healthcare delivery system. And so maybe you could share some thoughts on how do we merge those two different sets of priorities. How could practice-based research networks be one of those building blocks for learning healthcare systems? And then the big question to me is, when do we really stop saying this is a long-term thing? We need short-term process measures, but really start holding ourselves accountable. Have we moved the needle in a fair and equitable way? I know I've given you a lot to respond to, but you raised all of these questions today.
Yes, such wonderful comments. So if I can, so I believe you have two specific questions, but lots of really good points. So one specific question is, how do we address learning health systems and make them work in very different settings of maybe academic type centers versus PBRNs and lower resource FQHC type settings? One
Right.
question.
Yep.
Yeah, I think it's, of course, an excellent question. I don't have the answers. I can think out loud with you for a minute. I am finding that I think, I transitioned recently over to the Department of Family Medicine at University of Colorado. And you want to know why I did that? Because they have such a strong PBRN network. And I see that as a really strong form of a learning health system, but it's external to the health system. And that's what excited me. And I want to learn from that. So in many respects, I think PBRNs are already doing this work. As you point to, the metrics and the short-term objectives might be different, but I think that it's still aiming for the same purpose of a learning health system. They're just doing it oftentimes with fewer resources and oftentimes more efficiently and effectively than we are. I might not have answered your question there.
It's a start. Thank you.
And then the second question, can you pose the second question one more time, please?
Yeah, so the second question was, at what point do we really hold ourselves accountable to measuring the benefits or the impact at the public health level? So if all these things work together to produce better quality, better value, we ought to see an equitable improvement in health, reduction, elimination of disparities, reduction in events of cardiovascular disease, cancer, et cetera. And yet the short answer that we all give is, well, that's more than a 5-year grant cycle, so we can't really measure it. Or we have a lot of people who are not in the health system that are in the same geographic area, so we don't want to be accountable for their event rates in our denominators. But what I'm saying is, maybe part of the answer to that is the interoperability of networks that would allow a broader coverage of that. And I offered PCORnet as at least a work in progress to try to get us there. And so I wanted to hear from you. When do we start to say that the true outcome that we strive for is measured in public health statistics?
Yes, thought-provoking. I don't have the answer, but I think we are getting closer. I agree, PCORnet, PedsNet are good examples. The Cures Act that just happened, I think, is really helping us be accountable for that interoperability and giving us the means to actually push towards it as well. It's not going to be overnight. It probably won't be in 5 years, I wish it was.
May I jump in and ask a perhaps provocative question? New regulations have been released for sharing data from different studies by NIH. So I wonder what your reaction, and Jonathan, I would love your perspective, just to put a question to you, and thank you for being here. Do you think that those efforts of requiring data sharing from grants and perhaps data harmonization efforts will take us closer to this?
So I'm sorry, Borsika, was that to me or to Katy?
Yes, yeah, if you don't mind, Jonathan, I
Okay.
would love to hear, because that I know that it came up starting January, and we are still figuring out what this means. But I was wondering if you felt that those efforts will be bringing us closer to be able to have those measures.
Well, certainly the second part of your question, interoperability, gets us closer. The data sharing requirements, I worry about the liability of re-identification. That's the biggest risk to that kind of data sharing, and what kind of protections we have in place. It's one thing when you curate the data and keep it behind your firewall. It's another thing when you hand it off to somebody else that you can't really control. But I don't want that to be what limits us from accomplishing great things. So I think, again, it goes back, Katy, you talked about governance requirements, governance and oversight that are going to be necessary to discourage re-identification or inappropriate use of data, while at the same time being able to link all of these vast resources that right now are siloed, but could really give us a much better image of population health.
Yeah, I think I agree. And Borshika, in the new data sharing standards, I'm not sure that it is so clear to every. I think it's put forward. Let's see if we can reproduce and validate the findings. But you bring a really good point that maybe there's another use for that data to get to Jonathan's point of true public health impact. I love it. Great idea. Susan, you've had your hand up. I'm so sorry.
No problem. I was playing off a couple of things. Jonathan had said that that with the public health and healthcare systems having similar long-term objectives, but having challenges getting them to work together to get there. And what is just a quick thing, I think if you include, just like how you want to plan your research studies around the possibility for implementation and sustainability, and if you plan that at the beginning, it'll become more successful. I think the same thing is I think in a lot of these research studies, if you planned it or had part of the team, and I think somebody put in the chat about the team, what makes up this team, if you have primary care physicians as part of the team at the beginning of your research, at that point, as you start saying, well, we could do this, we could do that, you'll hear, yes, that's a good idea. No, that's not a great idea. A big issue around it is data entry stuff. Who's going to enter that data? And it just automatically seems to fall in the lap of the primary care physician, which then creates a lot of pushback at a systemic level. And so if you incorporate that early and try and do things more, computer generated or lower salary patient, workers who you can hire more of to do that I think you will find more success if you do that, because everybody does want the same outcomes, but you need to have outcome, as Jonathan was saying about having that long-term picture. That's what sells healthcare systems on this. The reason why we now have the medical home is because outcomes data of decreased morbidity and mortality is why they're willing to put money into that, because they've shown that that's proof. So until you look, it's kind of a chicken and egg. Until you have that longer term outcome data, you're not going to get the finances to get the outcome data because that's what is going to change. That's the only way healthcare systems change, is it's all about time and money. And so they'll spend their money on things that have been proven to change outcomes, whereas when they're in the more basic level, there's a lot of reluctance to spend money on that.
Excellent point.
Thank you so
Julie,
much, everyone. Katy, you are being very, very generous with your time. I wanted to check because we finished officially at 3:15. If you have time, Julie has a question, I think, and that might be the last one that we take on, but I just wanted to encourage everyone to stay on as long as you can, but know that we are over time, and I really appreciate everyone's presence. So Julie, please go ahead.
Okay, well, if Katy can stay on, I want to be respectful of your time. Just kind of building off of this governance and accountability thread that's been woven, I'm curious how you're integrating the patients and community into the decision-making process, and also how you're closing the loop with enhanced dissemination beyond, like you said, the peer review process. Just curious at your experiences with those.
Yeah, so it depends on, when I break down the 2 learning health systems that I'm really involved in. There's the NAV Lab, which is more general, and then there's the Children's Hospital Colorado. Children's Hospital Colorado, our intent is to embed patients and caregivers within our overarching governance process. So they are there from the very beginning, are involved in everything that we do. For the NAV Lab and more general learning cycles that we do, I would say is we involve patients and communities selectively. And I think to a certain degree, it's necessary because you can only do so much. So for example, in the example that I shared of the EHR alert for heart failure prescribing, we engaged patients to make sure that the recommendations were patient-centered and aligned with what their preferences and social needs were, if there were barriers there. That's one example. Actually, that's a few different examples of ways we're doing it. It depends though. There was something else there that you asked.
The closing the loop and dissemination.
Yeah, we always do the peer-reviewed process, but we are trying to be more active about iteratively feeding back data, especially to the health system, because when they don't hear how things are going, that's when they forget about us and don't see our value. We're trying to do that to ensure that we have sustainable funding and build sustainable funding when it doesn't already exist. We're trying to get creative in using social media to disseminate our findings too. I don't know that we've been incredibly successful with it though.
Okay, well, I am just so grateful for this. Katy, thank you so much for being here, and all of you who stayed on longer and had very good questions to keep a very rich conversation. Thank you so much for joining. And Katy, I am sure that you are open for additional follow-ups via email if people couldn't ask all their questions.
Certainly, absolutely. Thank you all. Not only do I love talking about this, I learned so much from you all. So thank you.
Thank you.
Thank you so much.